I'd like to invite next speaker, Dr. Shivendra Singh. He is speaking up on is it Hilar Cholangiocarcinoma or CA gallbladder neck? How does it matter? Dr. Shivendra Singh.
Good afternoon, everybody. So there might be some overlap with the previous talk. So this is very important in our field where the gallbladder cancer is very common, and sometimes it is very difficult to differentiate whether it is a hilar cholangio or it is a gallbladder neck, and it is important. So coming to just an overview, the hilar block, the commonest malignant cause of hilar cholangiocarcinoma, gallbladder neck cancer, intrahepatic cholangiocarcinoma or SCC with biliary involvement or a biliary thrombus, cystic duct carcinoma, but it should have a clear-cut Ferrar criteria, should be qualifying, and benign IgG4 cholangiopathy, Mirzi syndrome, and xanthogranulomatous. These are more common in what we see in our practice. So why it is important? As you can see, the hilar cholangiocarcinoma involves the confluence till to the secondary confluence, and any tumor arising here is labeled as a hilar cholangiocarcinoma. Gallbladder neck, you can see it is very close to the right hepatic duct, and it might involve the right hepatic ductal system most of the times. So, but in sometimes, even with the histopathology, it is very difficult to differentiate whether it is a hilar cholangiocarcinoma or a gallbladder neck tumor. And then it has to be decided where the bulk of the disease is, whether the bulk of disease is in the biliary tract or it is a gallbladder cancer. If the bulk is there in gallbladder cancer, it should be labeled as a gallbladder neck cancer. Other thing is important on histology is the gallbladder neck is having a lot of cystic duct containing tubular alveolar mucous glands, which are usually not seen in the fundus or the body tumors. So this is the difference between the gallbladder neck and the biliary tract malignancies. Also important to note, if you see overall gallbladder cancer, the gallbladder neck carries a very poor prognosis, even as compared to gallbladder fundus or body tumors, and with a 5-year survival of 0% in gallbladder neck tumors. So these are the few scenarios I'll see, and keep these pictures in mind. I'll come back later in the part of my talk. This is a case of hilar block. You can see the confluence is just forming or not forming. It is very difficult to differentiate, and this hilar block is there. Second tumor, again, you can see there is bilobar IASBRD, there is a mass, and the GB is distended. This is another case. There is a hilar bilobar IASBRD. There is a thickened gallbladder, uniformly thick walled, and there is a hilar block with the right and left separated. Another case, you can see there is a mass at the neck, and there is a type 4 block. All the 4 biliary systems are separate. So these are 4 common scenarios that we usually see, and keep these things in mind. So why we need to differentiate? The most important is CAGB is more aggressive as compared to hilar cholangiocarcinomas, and the prognosis is much worse as compared to hilar cholangiocarcinoma. Chances of finding peritoneal mets are very high in gallbladder cancer, though it is very less than 5% in hilar cholangiocarcinomas. And the PET-CT is must for staging for gallbladder cancer, but we need not to do in hilar cholangiocarcinoma. We did a prospective study which was published as a consensus statement EJSO in 2020, in which we have shown that the PET-CT finds additional finding around 30% of patients, and the changes of treatment management plan in around 23% of patients because of finding of extrametastatic disease, which was not picked up on the CT scan. So overall change in management is more common with locally advanced cancers as compared to upfront resectable GBs. And with the distant metastasis, sensitivity of PET scan was 70% and specificity of 85%. And the false positivity rate was 7% in our study. So based on this UK guidelines also includes now a PET-CT in gallbladder cancer for staging purpose. And they have quoted our study for this. So second thing is, because the peritoneal mets are must, the staging laparoscopy should always be done in a gallbladder cancer, but you can omit in hilar cholangiocarcinomas because the finding of peritoneal mets are less than 5%. If you are planning a portal vein embolization in hilar block patient, if it is a gallbladder cancer, one should do staging laparoscopy before doing portal vein embolization, because in around 20% you will find peritoneal metastasis, and there is no point in doing portal vein embolization in these patients. Also, the extent of liver extraction changes. The segment 4B you have to resect always in all the patients of gallbladder cancer, which you can omit in hilar cholangiocarcinoma. If it is a type 3A lesion, you can leave a segment 4B part. Also, the extent of lymph node dissection is same, but the finding of lymph nodal disease is more common in gallbladder cancer as compared to hilar cholangiocarcinomas. So coming to status of vascular resection, as an SPD, the vascular resection and SPD, one can proceed if it is a hilar cholangiocarcinoma, because these are locally aggressive tumors, but chances of systemic failure is less. In gallbladder cancer, problem is of systemic failure or development of peritoneal disease. So these patients in which the vascular involvement is there, or the role of SPD is very less in gallbladder cancer, and one should try to divide any doing vascular resection or SPD in gallbladder cancers. Coming to the need of caudate resection, I will come, and the extent of biliary margin. Coming to the bile duct margin, you can see this is a gallbladder neck, which is close to the right hepatic duct. So most of the time it involves the right hepatic duct, but the involvement of going to an extension to a left hepatic duct is very, very unusual in CAGB with neck. And if you are finding on cholangiogram there is a segment 4 duct is separate, then most of the time it is a hilar cholangiocarcinoma, not a gallbladder neck tumor. So it is always you can get a good margin left hepatic duct with gallbladder cancer, which might not be is true in case of hilar cholangiocarcinoma. In hilar cholangiocarcinoma, as you know, there is a papillary, nodular, and infiltrative varieties. The papillary and nodular tumor are known to have a mucosal spread more than what you see in the macroscopic, and you can have a microscopic spread at least 220 mm as compared to the gross what you are seeing. For infiltrated tumors, at least submucosal spread is very common, and is spread more than 10 mm as you see in the gross. So you have to get at least 2 centimeter margin in case of papillary and nodular, and you should try to get at least 10 mm margin in infiltrative variants of a hilar cholangiocarcinomas. Coming to the caudate resection, you can see the caudate has 3 parts, the Spigel's loop, paracaval portion, and a caudate portion. As you can see, this paracaval portion extends up to the hepatic vein confluence, and the caudate process is on the left, caudate lobe proper is in the left side. If you can see the biliary ductal system, one are the paracaval portion or duct and the caudate process duct usually open the right hepatic duct, and the caudate lobe proper ducts open on the caudate left hepatic duct. So usually for a bile duct cancer, gallbladder cancer is usually going to involve right hepatic duct. So most of the time you can go away with doing a paracaval portion and caudate process resection. If you are doing an extended right hepatectomy, you need not to do a caudate lobe complete resection in gallbladder cancer, because involvement of left hepatic duct is very uncommon in gallbladder cancer. But if you are doing it for hilar cholangiocarcinoma, because it is infiltrating tumor type and the left duct is most of the time involved, it is better to do a caudate resection completely in the hilar cholangiocarcinomas. Coming to role of neoadjuvant chemotherapy, even while we are waiting for portal embolization. Being a hilar cholangiocarcinoma which is locally infiltrating, the gallbladder cancer is much more aggressive, and the chances of spread while waiting is very common, and that is why we have published our experience of portal vein embolization with neoadjuvant chemotherapy in gallbladder cancer. And we have proposed, because if you are going to wait for 4 to 5 weeks to grow, at least 20% of patients will develop metastasis or progress in while waiting for liver to grow. So we use a portal vein embolization while waiting, even if there is no other indication of going. This is what we have proposed. If the hilar block is there and you do a portal vein embolization, you are going to wait. So while waiting, you give at least 2 to 3 cycles of chemotherapy in these group of patients to prevent progression while waiting. Coming to role of adjuvant chemotherapy, the gallbladder cancer definitely at present we should be using a adjuvant chemotherapy, either a gemcitabine or capecitabine at least should be used in all T2 or node positive tumors. For biliary hilar cholangiocarcinoma, most of the time it is a local failure, the systemic spread is less. So still the adjuvant chemotherapy is doubtful, but BILCAP trial has included a hilar cholangiocarcinoma also, and was around 20-22% of patients of hilar cholangiocarcinoma. So based on evidence, the hilar cholangiocarcinoma should also be given an adjuvant gemcitabine or capecitabine. The transplant is not indicated at all in gallbladder cancer, being a very aggressive tumor, but hilar cholangiocarcinomas in selected group of patients, you can follow the Mayo protocol and select your patient for hilar cholangiocarcinomas. So coming to how to differentiate, if you go by clinical symptoms, the associated pain more is common in gallbladder cancer. In the hilar cholangiocarcinoma, it is usually a painless progressive jaundice. The pain is very less presenting symptom in hilar cholangiocarcinomas. If the gallbladder is palpable, most of the time it is gallbladder neck, not a hilar cholangiocarcinoma. On CT scan, if you find a mass in the hilum GB fossa, always gallbladder cancer is first possible. GB distended, then also it goes in favor of gallbladder cancer. If it's a bulky nodal disease, then most of the time it is a gallbladder cancer, not a hilar cholangiocarcinoma. And even in presence of omental peritoneal disease favors gallbladder cancer. And vascular involvement, especially if the left portal vein or left hepatic artery is involved, then most likely it is a hilar cholangiocarcinoma. Very unlikely for GBC to involve left hepatic duct or left portal vein or left hepatic artery. So coming to the MRCP, the extent of biliary involvement, you can see that whether it's extending to the left duct, segment 4 duct involvement is there, then the most likely is a hilar cholangiocarcinoma. So these are the indirect indicators whether it is a hilar cholangio or a gallbladder cancer. EUS also or a cholangioscopy can be done, but is most of the practically it is most unlikely to be used because unless you are going to take a biopsy for doing neoadjuvant chemotherapy, there is no need to do a EUS or a cholangioscopy to diagnose. So coming to this, you can see this patient had a PTBD on the left side, there is a block, the right hepatic artery is attenuated, and this was a hilar cholangiocarcinoma, and we did a portal vein embolization followed by extended right hepatectomy. This is another patient, you can see, notice there is a mass in the gallbladder neck here, you can see, and this GB is distended, and this goes in favor, it's a gallbladder cancer, and this is the cholangiogram, though in this you can't see the distended GB because it is filled with the thick sludge, so most of the time, many times it's not visible. So in this also we did a portal embolization followed by dissection, and this we can see there is no caudate dissection we have done. And this again you can see there is irregular thick wall GB, again the mass is there in the GB fossa, this is a gallbladder cancer with a hilar involvement. This is another patient, you can see there is a bilobar ISBRD, there is a mass in the GB neck, and GB is distended, you can see the distended GB with a thick sludge filled in it. So this also is a gallbladder cancer. But in spite of this, many times you will be failed at least in at least 20 to 25%. It is many times difficult to differentiate. It is a gallbladder neck or a hilar cholangiocarcinoma. In this is a case we recently operated. This is a thickened GB wall, and there is a mass. GB is distended. Hilar block is there. Patient presented with jaundice. We did a PTBD, and followed by our thinking was it is a uniformly thickened, could be a xantho, but we are not able to prove histologically. So we went ahead, you can see there's a colonic involvement was there. We did a segmental colectomy, did a distal gastrectomy and duodenal resection, and 4B and bile duct resection. And final histopathology came out to be xanthogranulomatosis cholecystitis. So another patient, this you have shown, this is a hilar block with almost type 4, all ducts were separate. We can't do any surgical resection in this patient. We did a US guided FNAC and biopsy. It was suggestive of IgG4 cholangiopathy, and it was treated with steroids, and patient improved. So to conclude, it is important to differentiate the hilar cholangiocarcinoma and CFGB neck, especially more from the prognosis point of view, but still it will be, many times it will be difficult to differentiate even with all the investigations. Being in endemic area of gallbladder cancer, it is better to investigate and treat hilar blocks with CFGB in mind rather than hilar cholangio in northern India. Thank you.
Thanks for the nice presentation, Dr. Singh. Any questions from the house?
Dr. Shivendra, that was a very nice presentation. Just only one question. You made a statement that while you were differentiating in the approach between the CAGB versus hilar, you said that in CAGB you have to remove 4B. Yes, well accepted. But you also said that in hilar you need not do the 4B resection. But the basic, if you have to leave behind 4B, then you will have to lower the hilar plate, and you don't want to touch that area.
You can remove part of inferior part of 4B, but you don't not really complete as you do in the gallbladder cancer.
The idea behind doing an extended resection for a hilar cholangio CA is basically not to touch that area. So you take
For
it on block.
Type 3A block, you can go ahead with right hepatic and caudate lobectomy, and you can take a 4B, a part of inferior part, but not typical that we take a full info 4B in gallbladder cancer. You can avoid doing a 4B completely.
Oh, because my idea was that you
Yeah,
don't
you
touch
don't
lower
do
the
hilar
plate.
dissection is
Yeah,
not
hilar
done. That is
dissection should
completely
not be done.
But you don't need not to complete do 4B resection like in gallbladder cancer.
Shivendra, I fundamentally slightly disagree. We don't need to remove the 4B completely, even in gallbladder cancer, except when there is remarkable amount of liver infiltration. That's the fundamental of the formal resection. That's what principle we follow. We take a large wedge, you don't have to formally remove it, unless it is a T3 tumor, in which case you will remove that amount of liver.
This
with
is
a margin
very
anyway.
controversial whether you do a complete wedge or 4B. There is no direct comparison. We are doing a randomized trial, but I think we'll be closing this year. So we'll come out to whether 4B is better, complete anatomical, or wedge will be better.
Because that solves your problem. You have to remove just a part of 4B in both.
But I think there is a lot of data from the concept point of view. There is a micromets which are seen around 20 to 30 millimeters, even in T2 tumors of gallbladder cancer. And there is a angiolymphatic invasion, not direct micrometastasis along the spread along the portal tracts. So that is the hypothesis, but I think whether it will be differentiated, there is no level 1 evidence at present, wedge versus segment 4B complete.
Sir, my question is regarding patient who require portal vein embolization before surgery for gallbladder cancer. Does it affect the kinetic growth rate when we simultaneously do portal vein embolization and give chemotherapy while waiting for surgery?
So if it is jaundice, we usually take a 40% of a remnant liver volume should be there. That is our cutoff for doing a portal vein embolization for cholestatic patients. Regarding the effect on the kinetic growth, the effect with the chemotherapy is not there. There is always growth is there. This is very commonly used in colorectal liver metastasis, and they have shown that while doing a portal embolization, you can continue with chemotherapy.
Yes, sir. I have seen literature in the colorectal liver mets, but I haven't. I wanted to know your experience.
Our experience, we have not found any difference.
Thank you, sir.
Shivendra, if you have 10 patients or 100 patients of hilar block, in your experience, how many of them will be CAGB and how many of them will be hilar cholangio? And of these, how many CAGBs are resectable and how many cholangiocarcinoma are resectable? Just a rough idea.
Roughly around our setup, we found the hilar blocks, roughly around 60 to 70% we see CAGB, rest 30% are hilar cholangiocarcinoma. But hilar cholangiocarcinoma might be resectable around 70%, but in gallbladder cancer, it is only 15% are resectable.
May I ask, at your institute, those who have undergone R0 resection, what's the recurrence rate, relapse, after median follow-up, let's say 12 months?
For gallbladder cancer?
Gallbladder, perihilar,
The gallbladder cancer, the most of the time recurrences are systemic, either in the liver and liver mets, liver discontinuous liver mets, or a peritoneal spread in the form of ascites or multiple. But these are the three common sites that we have found. And roughly in the 2 year, roughly around 30% will have recurrences.
That's better than what's in the literature.
Yeah, it is. I think we have been more aggressive in using adjuvant chemotherapy. That could be one of the reasons. And we have published our approach of multimodality also recently, and that is published last year also, whole experience of it.
Shivan, very nice actually, I really enjoyed it. So I think it's very important to differentiate, and you really made out the points very clear. And the most important thing is with the neoadjuvant chemotherapy or chemoradiation, especially with gallbladder cancer, because we all have seen, we have resected many of them and they don't have a good prognosis. And sometime actually then on occasion you do end up doing an HPD as well. And again, HPD in gallbladder cancer, they don't really do well. So we achieve a level where whatever we can do surgically is maximum now. So we really need to find ways where we can augment the therapy in order to improve the outcome. And that's why I think it's very important to differentiate between these two diseases so that we can give neoadjuvant chemoradiation in cases of gallbladder cancer presenting with obstructive jaundice. And that will actually improve the overall prognosis of this patient rather than actually just attempting to do more, being innovative in terms of how much surgically we can do on these patients.
Yeah, definitely, I totally agree. I think neoadjuvant and if targeted drugs or immunotherapy comes, with the neoadjuvant, and we have to find the molecular data from the gallbladder cancer to find new answers.
Hello, sir. So you mentioned about primary cystic duct carcinoma. So in a case scenario, if we send it as frozen and it comes as primary cystic duct carcinoma, how
very
much
difficult to wait. Only in the literature-wise, only 30-40 cases are reported of
Yes,
cystic
sir.
duct carcinoma.
Yes, sir.
So practically, you should forget it as cystic duct carcinoma.
Okay, I just wanted to ask about the liver resection. No, okay, fine.
In our setup, it will be gallbladder cancer only.
Thank you, Dr. Singh.
Thank you.